I'm going to talk about, I say a GI station, is mainly going to focus on the interpretation of LFTs, but I'm going to just talk briefly as well about what might be found in an examination and things with in an LFT liver kind of station. So without further ado, let's get going. Move on. So by the end of this session, I want you to be able to recognise clinical signs in liver patients. But you're all kind of, I think, near kind of final year medical students. So I think you probably know most of them already. So I don't think I have much to add there. I want to give you an approach to interpret LFTs, particularly in OSCEs, because as if you were in the LFT chat earlier, we know that OSCEs in real life aren't always the same. And sometimes having a nice OSCE technique is more important than for in real life. And then a very, very brief chat about what to do about abnormal LFTs, which will be maybe one slide at the end. But if you have any questions, then I'll also have time for that as well. So I need to stop. I need to close my emails. You're seeing all the Groupon vouchers that I get every day and never use. Right, here we go. So why is this important? So liver stations are very common and both in real life and in OSCEs. So for that reason, I'm just going to quit my email. For that reason, you need to know a bit about it anyway. And the thing about the liver is it gives you lots of clinical signs. So when people are thinking about what to do, say as an OSCE station, they want something that can actually be seen, can be tested. Inflammatory bowel disease gives you some clinical signs sometimes, but not really as much. Liver disease gives you a whole plethora of things. So if I was in setting an OSCE station for GI, gastromedicine, I would think more along the liver side than the IBD side. So it's common, and you need to know what to do about it. And some people get themselves all in a tizzy about it. So hopefully by the end of today that won't be happening. So when you hear that phrase, the stigmata of chronic liver disease, which is all very posh, isn't it? What springs to mind? Anything? Oh, is it working? Hopefully. It is. Kappa-Medusae, jaundice, hepatitis, spider yes. All these things you read about in books. Anything else? Anything else? All very good things, by the way, all totally right. Jaundice of the sclera, yes. Asterix, yes. Absolutely, that's my favourite. If one can have a favourite dodgy liver sign. History of alcohol, absolutely. Yep. Hepatic flap, yes. Same as Asterix, wonderful. Upper GI bleeding, so hopefully you won't get that in your OSCE, because that'd be a bloody faff, wouldn't it? But yes, absolutely. Pain, pulmonary erythema. All these things are very accurate and all very true, and all kind of a bit abstract, I find. And I found that when I was a medical student trying to memorise all of these, I would forget quite a lot of them. So I'm going to try and see if I can stop that happening. Ascites, absolutely. Pruritus, wonderful. Everything to do with the liver and liver disease can be related to the scar tissue, essentially, that forms in the liver. So if you are cirrhotic, if your liver is cirrhotic, that just means that your liver is full of bad tissue. And when it's full of bad tissue, the liver can't do what it's meant to do. And as you will know, you've done kind of scientific medicine more recent than I have, but the liver does a hell of a lot of stuff. And if that is then all filled with the scar tissue and it can't do it, lots of things go wrong. So I'm trying to keep it really simple because I tend to try and think simply. So that's everything that happens in liver disease can be related to the scar tissue, essentially. So just on a mechanical level, if blood can't get through the liver, what happens? So it has to go somewhere because the blood is still there. So it needs to backtrack, and it backtracks to the nearest organ, which is the spleen. The spleen gets bigger. The spleen's job is to destroy blood cells. When it gets bigger, it's like, wait, I can do this more now. You get pancytopenia. That's one thing that you get with liver disease. Obvious, right? It also backtracks into the gastric vasculature, the mesenteric vasculature, and that is why you get Kappa-Medusae and distended veins. And even though you can't see it on an OSCE, viruses. One of the things that the liver does, and I'm not going to pretend to know the full pathway, but it metabolizes estrogens into its different byproducts. And if it can't do that, then you get too much estrogen. And we know that the increased estrogen in people with liver disease gives them pulmonary erythema, spider nevi, and gynecomastia. So that's why you get that. Again, if blood can't get through the liver, one of the main jobs of the liver is to get rid of stuff and get rid of bilirubin and conjugate it. And if it can't do that, you get jaundice. And another main job of the liver is to get rid of toxins. And if you can't do that, the toxins build up and you get hepatic encephalopathy, which is why you get the flap. So when you think about it, pretty much everything we see in examination is very relatable just to the fact that there's scar tissue in the liver, blood can't get through it, and the liver can't do its job. All right. So if you can just think of it like that, rather than just trying to memorize random signs, I find that quite helpful. That's it. So everything you've seen in a liver examination or an OSCE, you can relate back to scar tissue. Right? Simple. Medicine's easy. Medicine is easy. So that's all I'm going to say about clinical signs. You're all final year medical students. You'll all have that very much under wraps, I suspect. So say you've gone in, you've done a wonderful history, you've done a wonderful examination of this liver patient, and you get handed blood results, okay? Here they are. So the bilirubin is 60. I'm not going to read it all out, but the thing to draw your attention to is the bilirubin is quite high. The albumin is 18. The ALT and AST are slightly raised. And the ALP is also slightly raised along with the GGT. So what initially comes into your head when you see that? Is it panic, or you're like, I know what this is? What are your initial thoughts? Go for it. Let's hear them. I'm excited. There's always this moment where you wonder if Menti has stopped working and you're just looking at a blank screen, whatever. Unless you don't have any initial thoughts, and that's okay too. You can put them down.
It should be working, but some people are also writing in the chat saying...
Oh, okay, fair enough. Hepatitis, yep. Hepatic failure, yep, okay, fine. Probably need to be a wee bit more specific than that in OSCE, don't you? Anything else? What else are people thinking? Hepatitis, yeah, okay, hepatitis. Acute hepatitis? Chronic hepatitis? I could show the labs again, hold on. Take 30 seconds. We're going to go through it anyway, so and again, if you get it wrong, I really don't care. And not narrows anybody else, just go for it. All right. Raised bilirubin, absolutely. Acute pancreatitis, interesting. Yep. Drug overdose, interesting. Raised ALT. Yep. So what I quite like about some of these is that you're just saying what you see, which actually is not in OSCE is pretty important, isn't it? Not acute pancreatitis. Okay. Interesting. We're going to get a fight. Chronic liver disease due to decreased albumin, post-hepatic jaundice, mixed picture. So I can kind of see already primary biliary cholangitis, somebody's thinking. So you can already see that we're already getting quite a few different ideas here. And that's because LFTs are quite difficult because they're quite nuanced, they're quite specific. Hopefully by the end of this presentation, this becomes easy, right? So here we go. Let's make this easy. That's my whole motto in medicine. Please make it easy. It's hard enough as it is. So we need a quick, easy cross test that under pressure you'll be able to work through and get a decent answer. All right. Oh, thanks, Daniel. That's helpful. So the first thing you have to look at is which is higher. Is it the ALP? Is it the ALT? All right. That's the first thing. AST may or may not be there. ALT, ALP. If ALP is higher, ALT is higher. So let's say, for instance, that the ALP is higher. The next step is to check the GGT and the calcium. If the gamma GT is also raised, then you're looking at cholestasis. You're looking at gallstones. You're looking at an obstructive picture. If the calcium's higher, it's likely bones. And that's it. Right? Stop there. Okay? Because that's all we can tell. So if the ALP is higher than the ALT, go down this route. GGT versus calcium. And if the GGT is higher, you think cholestasis. If the calcium is higher, you think bones. Right? That's ALP. Done. Okay? If the ALT or the AST is higher, then you think, right, is it very high or a little bit high? If the ALT is very high, and I'm talking over 1,000, like, whoa, like one of those ones you get up in the computer and you think, oh no, I'm not finishing on time tonight. If it's that high, then you're thinking acute liver damage. So acute hepatitis, paracetamol overdose, for example, an acute liver picture, ALT will be through the roof. ALT is a little bit high, right? We need to do some more steps. We have to check the synthetic function of the liver. Is the liver able to make it? Next, synthetic function. So that all I mean by that is the bilirubin and the albumin. If the albumin is low, the liver isn't able to make albumin. That's why it's low. The liver makes albumin. That's why it's low. The liver isn't working. If the bilirubin is high, it isn't conjugating bilirubin, it isn't getting rid of bilirubin, the liver isn't working. So if the ALT is a little bit high, the liver isn't working, and that's probably because of a chronic issue. Right? That's it. Okay? Brodowski, that is all I want you to know. Okay? Now, in real life, LFTs are deceptively very normal in some patients with 10 years of cirrhosis behind them. But again, we're thinking about OSCEs here. Will that likely be the case in the OSCE that are going to give you normal LFTs? I would hate them if they did that, and you'd be very right in saying, oh, they're normal. So I think in an OSCE, it'll be deranged in some way, and that's how you go through it. Okay, so remember that process. Write it down, memorize it, take a photo, whatever. ALT versus ALP. If ALP is higher, you're going down the cholestasis versus bones route. Check GGT and calcium. If the ALT is higher, if it's very high, acute liver failure. If it's a wee bit high, check the synthetic function. If that isn't working, you have a chronic picture. LFTs. That's it. Easy. Simple, hopefully. So let's apply it to what we've just done. So here they are again. So, what I want you to do is to go through our process. Which is higher? Do this in your head, okay, and then we'll talk about it next. Which is higher, ALP or ALT? If it's ALP, do your calcium and GGT thing. If it's ALT, AST, think, is it very high or is it a little bit high? If it's very high, we know what the answer is. If it's a little bit high, what's the synthetic function? If that's deranged, we also know what the answer is. And the LFTs are happily in the chat as well. So, let's look. Which is higher, ALP or ALT/AST? Go for it. That's all I want. Just tell me ALT or ALP. ALT, correct. I don't need all of you to answer this because I hope it's pretty self-explanatory. Yes, ALT. You're so right. You're getting you're wonderful. You're smashing it. It's wonderful. Awesome. Wonderful. You're so right. ALT, AST. And by the way, just to clarify, I'm mainly focusing on ALT because AST, as I'm sure you all know, is pretty non-specific. It's much more like, it can go up in liver, but it can also go up in like cardiac issues. It can go up in a whole range of issues. ALT tends to be a bit more specific for liver. So that's why I'm focused on ALT for the liver. Okay. Okay. Is the ALT very high? Over 1,000? Yes or no? That's all I need. Yes or no? No. I maybe could have made this a yes or no multiple choice question actually to prevent you all having to type out the same thing. For next time. No. Yeah, no, it's not. It's a wee bit high, isn't it? It's a wee bit high. It's like I did here. I was much smarter with this one. Well done me. Is synthetic function deranged? Yes or no? Let's see. I think I must have made these initialized after a shift. Go help me. Isn't it? Yeah. So remember, we're looking at the albumin, we're looking at the bilirubin. The bilirubin will be high, the albumin will be low if the liver isn't working. Yeah, you're smashing it. Amazing. Everyone's getting it. Nice and blue. Yeah. Does anyone think no? Does anybody think no? Oh, I don't even need to be here, really. You're all wonderful. You're all doing this perfectly. So, now, what is the most likely pathology? Is it acute cholangitis, acute viral hepatitis, sepsis-induced liver injury, or alcoholic cirrhosis? I'll give you 10 seconds. Yeah. So you can see that just by going through this process, we eliminate all the other options. It isn't cholangitis because the ALP would be higher. It isn't acute viral hepatitis because the ALT would be much higher than it is. Acute liver injury secondary sepsis, again, the ALT would be much higher. Also, arguably, the bilirubin wouldn't be as high. It must be alcoholic cirrhosis, a chronic liver issue. And we've worked that out just by using this process. In an OSCE, it's all about process. Diagnosis, actually, that's one mark, remember. So if you use our process, it's perfect. And you've all worked out. So yeah, alcoholic cirrhosis. So you've worked out that maybe this is alcoholic cirrhosis in your patient. The examiner might be then, right, so what do you want to do now? What investigations are next? What next investigations? An ultrasound. Interesting. Anything else? Abdominal ultrasound. Anything else? Keep going. You're wonderful. A full liver screen. Interesting. A fibro scan. Oh, somebody like gastroenterology. Hepatitis screen. Upper GI endoscopy. Interesting. Good point. Yep. A CT. So a lot of people are saying some sort of imaging. Anyway, absolutely. Okay. Anything else? Anything else? If not, that's fine. Clotting profile, yeah, absolutely. I would want a clotting profile, a CT hepatitis screen. So everyone's kind of saying you're dating all along the right lines. Again, alcohol history. Call a senior. Call me. Yay! Do it. I would love that. I would love this phone call. Except it was 9 p.m. and then I would be slightly unhappy. But yeah, absolutely, call a senior is never a wrong answer. It probably sometimes is the wrong answer in OSCE because you end up being the consultant gastroenterologist for the day. But in real life, absolutely, ask a friend. Okay, so again, I'm going to try and simplify this. At our stage, FY1, well, and even at my stage actually, before you get to gastroenterologist registrar, there are two main things that you're going to do if you get these blood results. You're going to do an abdominal ultrasound and you're going to do a liver screen. The abdominal ultrasound, because also you can say, oh, I think from the bloods it's most likely to be alcoholic cirrhosis or cirrhosis of some description, but it could also be chronic hepatitis. It could be so many things. It could be a chronic autoimmune issue. So you have to look for, it could be cancer. You have to look for other stuff. And the way you do that is an abdominal ultrasound, and that is first thing. So you would look for any structural abnormalities, any gallstones, just in case it's thrown up something a bit strange, or any tumours. Hepatocellular carcinoma is pretty rare in people who don't already have alcoholic cirrhosis, but important to check for it. And then a liver screen. Liver screen has about 1 million blood. I don't know if you've had the joy of having to take a liver screen of a patient. It's like 10 bottles or something ludicrous, and looks for hepatitis, all the autoimmune causes, metabolic causes, tumour markers. And that, as I say, is a whole other very long lecture that I'm not going to bore you all with, and I don't have time to bore you all with today. But again, in an OSCE, so future doctor, you've given me a good answer there that you think this is potentially a chronic liver issue. What do you want to do now? Abdominal ultrasound in the first instance, liver screen, and then actually after that, in reality, refer to gastro. Unless it's gallstones and then it's surgery. And that's it. That is the liver. If you get a liver station, that's all you have to do. You've smashed it. It's wonderful. So let's summarize this. LFTs in life will get a bit complicated because it's never clear cut in real life. But in OSCEs, this is how it will go. You need to do this process. And under pressure, if you've practiced this loads of time, you'll get it. And the only two investigations I would recommend that you ask for is either a liver screen and an abdominal ultrasound. Now, somebody said a clotting profile. Absolutely. That would probably already be done. I imagine you will already get that because remember, pancytopenia and things like that. And another thing that the liver does is make clotting factors, which it can't do because of scar tissue. Everything is related to scar tissue. So LFTs can get complicated, but we need to make it simple because I don't like medicine to be complicated. Use this process. And then once you've worked out, is it more likely chronic, acute, or cholestasis versus bones, the main two investigations will be abdominal ultrasound, liver screen, and you're going to pass your OSCE.